gonna start. There we go. I'm just letting, we have our people rolling in, so I'm gonna let our attendees continue rolling in just before we get started. Look at like 10 more seconds. Okay. Welcome everyone to another episode of A Conversation. This is actually our first episode of 2023. I know we're, already through March, but we're excited to have with us today, Adebola Giwa, who is the Associate Medical Director of Clinical Development at Ascendis Pharma. Today, we are going to be having a conversation on factors related to growth and achondroplasia. But before we get started, we had this conversation yesterday. Adebola, can you please tell us just a little bit about yourself so our audience can sort of get to know who we're speaking with today?
Okay, no problem. And first off, thank you for inviting Ascendis and me to come talk on your show. It's a big privilege for us. In regards to who I am, as you correctly pronounced, I am Dr. Adebola Giwa. I'm a pediatric endocrinologist, and I'm the Associate Medical Director at Ascendis. I've been at Ascendis for about 3 years now, so I was there from the very early starts of our trials. So I'm the Associate Medical Director for all the TransCon CMP trials and also the Global Medical Monitor.
Very cool. And I know you are, I guess, first and foremost, an endocrinologist. How did you, what was there any inspiration or, what made you want to become an endocrinologist or get into endocrinology?
Okay, sure, yeah. As you said, I'm a pediatric endocrinologist, so I'm an endocrinologist for kids. For those who may not be very familiar with what an endocrinologist is, I am basically a hormone regulator. Hormones are the body's chemical messengers, and they're involved in controlling and regulating a lot of processes in the body. So when those things don't work well, kids can develop issues such as diabetes, thyroid problem, issues with puberty, too early, too late, and of course, issues with bone growth. We also help to manage that, as well as people who have concerns about both tall stature and short stature.
Very cool. So I know today, that's very exciting. I know today we are going to specifically talk about factors related to growth and achondroplasia. And so I believe you do have a little bit of a presentation for us to share with our audience today. So you are welcome to start sharing your screen if you want.
Sure. Thank you. I'll start sharing my screen.
And then obviously after Adebola, gives his shares with us what he has with us today, we do have a few questions that I will ask him.
Okay. Yes. Here we go. Yeah. Adebola Giwa. So yes, today I'll be talking about factors related to growth and achondroplasia. So, kind of full disclosure, when you first told me about this, I was really excited about your channel. So I kind of went and watched a whole bunch of the episodes. And you've had a really nice panel of people come and present in the past. And they've talked about a number of different things, from like, how do clinical trials work, achondroplasia, like how does it develop, how it is to live with it, both love and dating, as well as, school and bullying.
Mhm.
and different ways to treat it. So I wanted to do something different from all of that. So I figured I'd talk about things that are close to me. My bread and butter, as you said, I'm a pediatric endocrinologist, and regulating hormones. I mean, nothing gets my cortisol and glucose level up than talking about these things. As an endocrinologist, uh, we go over, we look, and we see how different hormones are regulated. One thing starts here and it goes there and tells you how to do that. So just being able to kind of close my eyes and see how all the hormones move around and being able to shift and then see how that manifests in people is really exciting. So growth is something that's really exciting for me. It's important for all people in one shape or fashion to grow. And this is a common question that I talk about with all types of my friends who may have concerns about their own stature or just curious about how their kids actually grow. So I'm going to be talking about growth and how that may be different in people with achondroplasia. And then also, again, full disclosure as well, I wanted this to be different. So this talk is meant to be more informational and not promotional. So I won't actually be discussing any transcon CMP things. So today's just the science and medicine.
Right. Sounds good for us.
Yes. So specifically, the things I'm going to cover are growth at different stages and what are the different factors that actually contribute to it, and how growth typically progresses afterwards, after growth in these different stages. And then also go over the different variations of growth that you may see in conditions such as skeletal dysplasia, like people who have achondroplasia. Okay, so first thing to start off, there are a number of different things that can actually determine growth in a person. And some of those factors play more of an important role at different times of your life. So, just as an example, if you think about birth and early life, the size of a newborn baby is actually largely dependent on their in utero environment or their environment inside the uterus when the baby was still inside the mom. Those factors include things like maternal nutrition. So, that's why it's so important that pregnant women and mothers make sure that they eat well. So, make sure that their babies can also grow well. Additionally, the actual environment inside the uterus, so the actual size of the uterus, actually plays a big role in the size of your baby. There's something called intrauterine growth restriction, which is basically means just the size of your uterus may be smaller. So if a baby inside their mom's womb is small, they won't have as much room to grow. And these issues can come about for various reasons during pregnancy and lead to a condition called oligohydramnios, which basically means it's just a lack of fluid inside the womb. So if you don't have a lot of room to grow, you could come out being relatively small for your gestational age. So, if you think about that, with that being said, a child, a newborn baby who has tall parents may be a small newborn if these intrauterine factors are at play, because it's more about those things in the beginning of life. Right after you're born, that's when those things play a bit of a bigger role. Things like genetics play a big role. So that's what you'll see. So over here on the right, I actually have a growth chart from the CDC. And just to help orientate you, over here we have the length in centimeters. And on the top over here, we have the ages from birth all the way for this chart going up to 36 months. And kind of how I explain to parents when I'm talking about a growth chart, they have these different percentiles on it that range, as you can see here, from 3 to about 97. So how I kind of explain it to parents, I'd say, a child, for example, is at the 50th percentile. I would tell them, imagine you take a group of 100 children. all the same age, all the same gender. If you're at the 50th percentile, that basically means you'd be taller than 50 of the kids that are there. So, for the most part, children will be born somewhere on this growth chart. But as I mentioned, after you're born, different factors start to come into play. You're born, and it's mostly the prenatal factors that determine your size. But you can actually wind up shifting where you are on this growth chart. You can move from the 50th to drop down to the 25th percentile or to the 10th percentile based on your genetic potential. So if you are born, for example, at the 50th percentile, but your parents are short and you're maybe destined to end up at the 10th percentile. So in the first 2 years of life, you could see kids drop down on this growth percentile as they move into their genetic potential, or they could move up based on their genetic potential. And then, if you think about the example I gave before with children who have intrauterine growth restriction and are born relatively small for their age, but they have tall parents, you may see what we call, catch-up growth. So in the first 2 years of life, if a child, for example, is born at about the 10th percentile, but their parents' genetic potential puts them maybe closer to the 75th percentile, you could see them moving up the growth chart in those first couple of years of life as they move into what their genetic potential is.
Mhm.
Yeah. Other things some people may not know, growth is actually seasonal. So you may actually see growth velocities increase in the spring and summer months. And sometimes kids actually will grow in growth spurts, especially during infancy. So you may see your kid eating a whole lot more than they normally do, and then they shoot up, and then they'll, kind of chill out with how much they're eating, and then the growth will slow down. So you could actually see infants growing in little bursts and spurts throughout childhood. And then, overall nutrition is always important. You hear parents always tell your kids, make sure you eat your vegetables, make sure you get enough sleep. Well, that's actually real. If you think about it, you eat food. Food is a source of energy for your body. So when your body gets food and they have to prioritize, hey, what are we going to do with this food? If you're not eating well, your body's going to say, hey, let's use this food for, everyday living kind of stuff, making sure you don't pass out, as opposed to, making sure you grow tall. So your body's going to prioritize your survival as opposed to your height. And, also,
That's a good way to word that. Prioritize survival over height. I like that.
exactly, exactly. Um, and different, it's not just food, also it's the quality of the food as well. Things like calcium and iron are important for bone development. So if you're not, getting your milk, not getting your cheese, getting your calcium, your body won't have that calcium to make your bones big and strong. And your body also releases growth hormone usually in cyclically. So while you're sleeping, your body tends to release more growth hormone actually. So that's why you'll see parents and moms say, make sure you go to bed on time if you want to grow big and strong. So, they actually know what they're talking about. It's actually based in medicine. So giving your body what it needs.
There you go for the kids. Any kids who are watching this, there you go.
I was not paid by any parents to say that, by the way. Okay. Yeah, now moving right along. So again, here I have more growth charts. So if you remember, the previous chart had birth to about 3 years old. This one has growth from 2 to 20 years old, both for boys and for girls. And as you remember when I was talking about how growth charts work and how you want to compare it and analyze it, it also is important to differentiate them by gender as well, because boys and girls grow differently. So just for example, after infancy, which is actually the time in life people grow the most, your growth velocity, or how much you grow in the course of a year, is most when you're a child in the first year or two of life. Then after that, it's relatively stable. And then the next big growth spurt that you have is actually during puberty. And this occurs differently for boys and for girls. So, just taking girls as an example, girls, so this one again, stature here, just to orientate you. Girls over here, got the pink one. Uh, we have height on the left, then we have age from 2 to 20 on the top. And as I mentioned, growth is relatively stable, through most of your childhood, school age. And then girls will usually start puberty, will go through puberty between the ages of about 8 to 13 years of age, with the most people going through it around 9, 10-ish for the start of puberty. The first sign of puberty for girls is breast development, and puberty usually lasts for girls around 4 years, but can actually, go as last as long as 8 years. So everybody's a little bit different. Usually puberty will stop around 16 years of age, and the peak height velocity, where you can kind of see where the height kind of peaks up here, is usually around 11 to 12 years of age. So you'll usually see that start to happen, maybe around 2 years after puberty starts. They'll have their peak height velocity. And then sometime after that, like are usually around 12 and a half years old, girls may go and start having their periods. And then after they have their periods, usually that's a sign that maybe girls have about 3 inches of height left in them. But as you can see, basically girls, they'll go through puberty between the ages of 8 and 13, and usually end around 16. For boys, actually, the progress is a bit different. It starts a little bit later in boys. For boys, it'll usually start around the age of 9 and usually start between the ages of 9 and about 14. And it'll usually stop around 18 years of age. And their growth spurt's actually later, usually around 13 or 14 years old, compared to the growth spurt that happens around 11 to 12 in girls. So if you think about that overall, puberty, it happens earlier in girls, but then also ends a little bit earlier. But for boys, it usually starts a little bit later and lasts a little bit longer. So how that may play out is, maybe you'll notice a class of 6th, 7th, 8th graders where most of the girls are taller than the boys. But then once you get to senior year of high school, you'll see the flip.
Mhm.
Um, yeah, so with that taken into account, the things that really determine your end height and how well how much you grow during puberty is both how robustly you grow during
Mhm.
puberty, as well as how long you grow during puberty. And that it can be best seen when you think about the timing of when puberty actually occurs. Some people will follow this curve pretty well, and they'll have an average tempo in regards to when they start puberty, when they have their growth spurt, and when they stop. But I'm sure, as you all know, everybody is different and everybody's special in their own way. So you'll have people who are early maturing. You may hear them be called early bloomers. And you have people who are late maturing, and you may hear them being called late bloomers. And we're very aware of that. It's very connected to family history. So if you usually see a kid, as I mentioned, for girls, they may start puberty around the age of 10. So if you see a girl who's starting puberty around the age of 13, there's usually a family history where one or both of the parents may have started puberty a little bit on the later side.
Mhm.
And the same thing for early as well. Some girls, even though it may start closer to 9 or 10, they may start showing signs of puberty at the age of 8. And it's not that when you start puberty will determine how tall you're going to be. As I mentioned, there's a number of different factors. Your genetic potential, your family history of how robustly you grow is one thing, but the timing only goes so far because, people who start puberty on the early side will also, puberty will probably also last the same amount of time as someone who starts puberty later. So, put that into a practical example. If puberty lasts 4 years, and if you're a girl and you start puberty at the age of 8 and finish at the age of 12, you're going to stop growing at the age of 12.
Mhm.
Versus somebody who may be a girl and starts puberty at the age of 11 and stops puberty at the age of 15. So this person had 15 years to grow, while the other person had 12 years to grow.
Mhm.
So if you take that into account, sometimes you may find that people who are late bloomers, they have more time to grow and they may, and, they'll end up at wherever their genetic potential will lead them. But that doesn't necessarily mean they'll be on the shorter side. They could wind up being on the taller side also because they may have more time to grow. And, sometimes if you talk to boys or girls who started puberty early, they may have been the tallest kid in their class in the seventh grade, but by the time they got to junior year of high school, they were one of the shortest people in their class because they may not have had as much time to grow.
And I just because I know we do get like some international audience members, but just when we say, for those listening,
Great.
when we say like junior year of high school, that's a like a 16, 17-year-old in the US. Just to like give them that numerical age. But yeah, that's kind of how it was for me. I to get personal, I started puberty when I was, I think, 13, and definitely, stopped growing by the time I was 16.
Exactly. Exactly. Thanks for that tidbit. And yeah, just as she said, junior year of high school, around 16 years age, and seventh graders are probably like
I
11.
think, at least in my experience, I know I turned 13, I think, in seventh grade, and then 14 in eighth grade, and then 15 in, freshman year. So that's how it
Mhm,
was for me.
exactly.
I think that's the kind of the typical in the US.
Hmm. Thanks. Yeah, it's been a while for me since I've been in the in the junior high. So
And just
yeah. All about how much, mixture of how robustly you grow and how much time you have to grow that'll, and other factors like genetic potential that will determine what your ultimate height and stature will be.
Mhm.
Okay, so now we're going to talk about different variations in growth. As I mentioned, there are a number of different things that come into effect when you think about the factors that affect your growth. One factor that's important to consider is skeletal dysplasia. And these are a number of genetic conditions that affect the development of the skeleton and the cartilaginous tissues. And the cartilaginous tissue is basically like connective tissue that's softer than bone. There tends to be more cartilage in infants and younger children. And then as children grow, that cartilage is replaced by hard bone. So there are a number of different genetic conditions that can affect how these grow. And There are a number of different types. There's a lot of different types of skeletal dysplasias, and they're characterized in a number of different ways, including the impact that they have on different parts of the skeleton, depending on the type of skeletal dysplasia. Um, so sometimes, for some people, they may have certain bones in their arms that are equally grow longer, or they unequally are shorter in different bones of their arms or the legs. For some people, this can lead to shorter stature. For other people, it can lead to taller stature. And as I already kind of mentioned, sometimes certain parts of the body can be different in how much they grow, and that can lead to body disproportionality. So for some people, their torso is not very affected. Um, and their extremities, their arms and legs may be shorter, relatively speaking, to the size of their torso, and that can cause issues down the line as they're working on independence. So that can happen in your arms, it can happen in your hands as well. And when are these things noticed? They're also different as well. Some of these can be noticed prenatally before you're born, and some of them can be noticed at birth. Just because these different skeletal dysplasias can have relatively subtle effects, and they may not be apparent until later on in life. So during pregnancy, for a pregnant woman, they'll have a number of ultrasounds in the first trimester, which is the first 3 months of pregnancy. And then they'll also have another set of ultrasounds in their second and maybe even their third, depending on their physician's recommendations. And during those ultrasounds that they do, especially at the second trimester, and sometimes if in a third, if they have that, they take note of the fetal anatomy or just different parts of the body to see how they're developing. So what they may notice for a baby who has skeletal dysplasia is they may notice from that ultrasound that some of the limbs, parts of the body, may be shorter than expected. At that time, they can do blood tests to test for different skeletal dysplasias from the genes. And speaking of genes, one important skeletal dysplasia is achondroplasia. They're all important in their own way, but achondroplasia is actually one of the most common types of skeletal dysplasias. And, I won't go too much into the mechanics of all this. I know there was a number of talks about it. But what basically happens is that there's a genetic variation in some of the cellular factors that affect growth. So, to basically say that this receptor, the cellular receptor, we'll call it FGFR3, one of its downstream effects is inhibiting chondrocyte differentiation, or cartilage growth. And of course, bringing it back to endocrinology, all about hormones, a counter-regulatory hormone is CNP, natriuretic peptide type C. And when I say counter-regulatory hormone, what I mean to say is these two factors kind of work as kind of a gas pedal and a brake pedal in regards to bone growth, so that people don't end up too tall or too short. So with this FGFR3 is basically the brake pedal, and with this CNP, it's a counter-regulatory hormone to stop the brakes. So you can think of it as a gas pedal. So FGFR3, brakes, CNP, gas. And what happens in people who have achondroplasia is that, as opposed to just having, gas and brake going on and going back and forth, you have the brakes down all the time with kind of just occasional gas. So with that, that leads to the issues with the the cartilage not growing as much because there's a constant signal from the body to limit and inhibit bone growth ultimately. This usually happens as a result of, I won't get too much into the genetics, but because of this gene over here, gain of function, which basically means this is always on. And about 98% of the people who have achondroplasia have a variation in this gene over here. And there's another small percentage of children who have the same features of achondroplasia, but their genetic variation is in a genes like this, but it's a slightly different change in it, but it leads ultimately to the same what we call phenotype, or kind of how you look in the end.
Mhm.
And what are the features? I kind of gave spoilers early on, but achondroplasia, as I mentioned, is a type of skeletal dysplasias, and skeletal dysplasias are kind of characterized by the impact that they have on different bones and cartilage in the body. So achondroplasia is characterized by something we called rhizomelia, which basically means shortening of the proximal limbs, which basically means the upper arms and the thighs are relatively shorter compared to the other bones. And as I mentioned, you can have similar features in other parts of the body. You can have it in the hand. So they have something sometimes. Some people with achondroplasia have something called trident hands, which is characterized a bit by shortened fingers, and then there's also some issues with the opposition of the third and fourth fingers. So their hands tend to be a little bit more in this type of conformation. These can also lead to issues with leg bowing as well. Also frontal bossing. So what that basically means is, as I mentioned, achondroplasia can affect different bones in the body, including the skull. So it'll affect the way that parts of the skull kind of develop, and different sutures or openings when they close and when they open. And that can lead to one of the things called frontal bossing, which basically means their forehead may look a little bit more prominent. The bones in the center of their face can also be relatively smaller. We call that hypoplasia. And because some of the bones in the center of their skull can be smaller, they can lead to issues with sleep, such as sleep apnea. It can also lead to issues with ear infections, because if you think about the bones that are also deep inside your ear, if they're smaller, there's less space for there to be there's less space, and this makes it easier for kind of germs to get trapped in there, leading to infections. And then, also more importantly, one issue that comes up that we really are concerned are sure to monitor in people with achondroplasia is something called foramen magnum stenosis. So, as I mentioned, it affects the skull, and it also affects the part of the skull where your spinal cord comes out of. So that's basically the part of your brain that goes down and puts nerves throughout your whole body. So that hole that the spinal cord goes out of can be relatively smaller. It can lead to impingement or kind of like tightening around the spinal cord. And that can lead to that's what we call foramen magnum stenosis. And this can also happen in parts of the spinal cord as well. We call that spinal stenosis. And that can lead to down the line, if it's not, treated or monitored appropriately, it can lead to issues with nerve damage, with pain, as well as walking. well, getting around easier. And just to name an example. But overall, how this may manifest in people with achondroplasia down the line is very variable. Everybody is, of course, different. Some people may see those issues that I talked about, and some people may not have any issues with it at all. For some people, it could be, if it does manifest, it could be relatively severe, while in other people, it may just be relatively mild. They could get also therapy to help them, and then it may not even be an issue at all for any of them. How does this affect their height in the long term as well? Over here in men, as I mentioned, boys, they go through their growth differently and they have a little bit more time to grow in comparison to women. So their heights can range from about generally 3'10" to 4'9" or 130 centimeters average. And a little bit shorter in women, about 3'8" to about 4'6". And then, but otherwise, outside of the things I mentioned, they're able to live full, healthy, happy lives. You may know some of them. There are a number of celebrities, some fans of a couple of them out there. I won't name them right now because, they're going to be, oh, Adebola's saying these shows are the best ones to watch. But they are really good shows. There are a lot of professionals. I have a lot of friends who have achondroplasia. Some of them are doctors. Some of them are leaders in the field. They're influencers. And they can live all different walks of life. It doesn't affect, there's no relation to having achondroplasia and it affecting your IQ. I mean, as I mentioned, I know lots of people with achondroplasia who are very smart, witty people, our host included. And I mentioned I know doctors that have achondroplasia as well. So yeah, able to live full, happy, healthy lives.
So, going back to, because, I think a lot of our audience, know, you know, about achondroplasia in a sense. But, thinking about, an example I always give is how, my sister and I were only 3 years apart in age. And so I remember, I don't think I know my sister won't watch this, but, but, knowing she went through puberty just, 3 years before I did, I don't think, it occurred to me how, would our experience through puberty be, different or not, or even when, through infancy. So basically what I'm trying to ask you is how similar is growth, during infancy and puberty in those with achondroplasia to those without achondroplasia?
That is a really good question. Taking it back, if you mentioned infancy, I mentioned that in utero, inside the womb, a physician may notice that there's shortened limbs, so shorter arms, shorter legs. But actually in growth, there's actually a fair amount of overlap. Not all infants are diagnosed in the womb. So what you'll actually see, if we overlap the growth curve for children with achondroplasia, is that there's overlap. So about the top 50th percentile of people with achondroplasia at birth, actually overlaps with about the latter half of the 50th percentile at birth. So, if you took two babies, one that has achondroplasia and one that doesn't, their birth length, I mean, it's not uncommon for them to have the same birth length. They may notice the shortened limbs, but there's actually a fair overlap right at birth. And then what you see after the first year of life is, there's an attenuation, there's a decrease in the growth velocity when you compare infants with achondroplasia to those who do not have achondroplasia. And how that looks like is, over here, we have the growth chart for people who do not have achondroplasia. And even though there's overlap of people who do have achondroplasia over the first year of life, first 2 years, because of the difference in the growth velocity, you'll see them start to kind of
Mhm.
deviate from the people who don't have achondroplasia. All that to say that at birth, there's a fair amount of overlap in length, but usually by, because of the differences in growth velocity, especially after the first 2 years of life, where, I mentioned people grow the most, you can start to see the differences there
Mhm.
um, their end growth and their length at that time.
And obviously, I know technology is not like, what it is today, but I know I mean, obviously I don't remember when I was born or even when I was in utero, but from having conversations, with my mom, and, we kind of talked about how, when parents, early on, you talked about like if parents, are tall or short. I was diagnosed at birth, just to kind of, give an example for anyone listening. Uh, I was diagnosed at birth, 1993, so, almost 30 years ago. But I don't think, they weren't concerned so much about my measurements, that like there was nothing that threw them off. I think I was maybe measuring, they just thought I was measuring petite, but why they weren't really so thrown off is because a lot of the women on my dad's side of the family were very petite as well. And so they just kind of like, oh, she may just, be petite and
Awesome.
things like that. Dwarfism, skeletal dysplasia was nothing in their radar because, our spines, kind of like you were saying, our growth does overlap a little bit in that time. So, that's my take on how maybe, if a child or a baby with achondroplasia in utero is not, there's no really signs or even symptoms of it, it could just be, we think, they'll just be smaller, but then we find out no. My next question, and, kind of leading up to, that is, I think, I know I am the only one in my family with achondroplasia. It was obviously came from a spontaneous genetic mutation, but, what are the likelihood of, any parents today who are watching who have a child with achondroplasia? What is the likelihood that their children, in the future, if, when they become grandparents and their children start to have children of their own, what are the chances that, their child with achondroplasia can then pass on achondroplasia to their future children?
Okay. Yeah, no problem. Those are all real good points, and thanks for sharing that. We were talking about people who have maybe on the smaller side in their family, so they don't really notice it at birth. And people with achondroplasia, they also go through puberty, but then as I mentioned, similarly, it's not as robust as people who don't have achondroplasia. And as we said, during puberty, it's about how robustly you grow, and as well as how long you grow as well, the length of time. So the length of time is about the same, but not as robustly. In regards to your other question in um, what can you expect? The interesting thing about it is that around, I think it's like around 80 to 85% of people with achondroplasia don't have a family history of achondroplasia, just as you gave in your example in your own family. Um, in regards to genetics, it's an autosomal dominant inheritance pattern. So what that means is if one parent has achondroplasia, there's about a 50% chance that their child could have achondroplasia.
Mhm.
And if both parents have achondroplasia, there's about a 75% chance that their child could have achondroplasia.
Well, that is good to know. I know we have been on, I can't believe we've almost been on for well, just over 45 minutes now, but I do want to say, thank you so much for your time today, for Ascendus's time today. I know that there are I think, some questions we can't answer today. So with that, I do want to say, and I know you have your information, thank you. But I do want to say for anyone tuning in today who, have any questions for Ascendus, you can reach them at their phone number provided or at medinfo@ascenduspharma.com, just to, so you guys can, you know, connect with them there. But other than that, Adebola, thank you so much for, tuning in and joining with us today, having a conversation with us. We would definitely, love to have you back to talk about, more, as we're in this moment in time. I think just growth overall, there's just so much growth happening overall in terms of achondroplasia. And so I think, we would love to have you back for another episode in the future. Thank you for being our first guest of 2023. Very excited about that. But other than that, again, thank you everyone for who tuned in today. We will definitely, let you guys know when this episode will be available. It may be some time, but we will definitely have more upcoming episodes in the future. So be on the lookout for that. And yeah, thanks.
Yeah, thanks again for inviting me. This has been a great experience. I love the show. I love the name too. I'm a pediatrician, so I love the puns. So it's been great having a conversation with you.
Yes.
And thank you all for listening.
Awesome. Thank you so much.